Good evening, all. Today, we'll discuss about the cataract incidence of cataract in companion animals, how to diagnose, and how to proceed with the treatment of cataract. So, as we all know, cataract is the most common intraocular condition in dogs and cats, especially in dogs. Yeah. So, coming to the anatomy of lens, just basic anatomy and physiology I'm explaining, nothing deep into the subject or theory. So lens, as we all know, it is a biconvex structure which is transparent and is located in the patellar fossa of the anterior vitreous. It is held in the position by the zonules or tertiary vitreous. These zonules are otherwise known as tertiary vitreous. That lens has the ability to change its refractive power by increasing or decreasing its thickness by means of the movement of the zonules or the ciliary muscles. And coming to the composition, 65% of lens is composed of water. It has a high protein content of 34%, high carbonic anhydrase enzyme concentration, and glutathione levels. And the lack of vascularity and nerve innervation makes it a transparent structure. And it is uh, composed of or formed by a lens capsule, lens epithelium, and lens fibers with very minimal intercellular and intracellular constituents. Very less intracellular organelles are there in lens fibers. So that also contributes to the transparency of lens. So coming to the basic anatomy, this is how a lens appears in a cross section of an eyeball. So, as I said, ciliary body and the zonules are attaching to the periphery of the lens, 360-degree, and keeps in its position. And it's not exactly a disc, or the anterior capsule is less curved compared to the posterior capsule of the lens. And by the movement or contraction of the ciliary muscle fibers, thickness of the lens increases and decreases, thereby the accommodation or focusing of the lens happens. So the various structures or various anatomical locations, this is more helpful when we describe the cataract. So lens bow is that arch formed between the capsule or nuclei and the equator. Like this is the lens bow. Then anterior capsule, which we see just after the cornea. Then comes the anterior cortex. Then the anterior adult nucleus, fetal nucleus, embryonal nucleus. So this is how the growth happens. Embryonal nucleus, fetal nucleus, then adult nucleus. Outside cortex, anterior capsule, posterior capsule. So in a dog, the diameter of lens will be somewhere around 10.5 millimeter and thickness at the center will be around 7.5 millimeter. This has importance when it comes to cataract cases where the thickness of lens increases due to the swelling of the lens material. And in cat, it is 9 to 10.4 millimeter in diameter and 7.5 millimeter in axial thickness. This is an average value, somewhere around 7 to 7.8 it will come. Then capsular thickness. Anterior capsule, this anterior capsule is the thickest basal lamina in the body, which is 40 to 50 micrometer in the anterior pole. And the posterior capsule is 3 to 5 micrometer only. And you might have seen especially in cataractous eyes, We can see a Y-shaped structure or the suture line in the anterior lens and an inverted Y-shaped suture line in the posterior lens. So that is how we differentiate whether it is in the anterior aspect or the posterior aspect. I'll show pictures later. Actually, these Y suture lines are formed by the lens fibers starting from the edge towards the center. They grow and interconnect as a Y suture line. They don't concentrate at the center. Instead, they form this Y-shaped interconnection. So, coming to the physiology of lens, 34% of protein, which is higher than any other tissue in the body. It is separated from the human body, or human or animal body's immunologic surveillance system in a capsule. So the protein is encapsulated. So it is separated or sequestrated from the immune response system. And when there is a damage to the lens capsule, that inside protein comes out and it can induce inflammation, severe inflammatory reaction or allergic reaction, like protein causes allergy, same like that. That is known as lens-induced uveitis. It can be because of a small leak of lens protein through the capsule, or it can be massive exposure, sometimes because of the capsule rupture or the lens gets ruptured. In such a case, massive exposure happens and that can cause inflammatory reaction, which is known as lens-induced uveitis. We will talk about it later also. And there is minimal intercellular water and there is a tight regular packing of the lens fibers that contributes to the transparency of lens. That changes in some condition and can cause loss of transparency also. So when you examine the lens, you have to examine from a side, not from the axial view. From a side, you have to examine that also. If you can use a slit lamp or a normal direct ophthalmoscope has a slit aperture. So that also you can use. Then you will be able to see that optical discontinuity. First line, what we saw, see will be the cornea. Then where the light hits anterior chamber, it is filled with aqueous fluid, nothing will happen. Again, light will hit at the anterior cortex of the lens. Then comes the anterior nucleus. This will be difficult to differentiate. These two we can easily differentiate by using a slit of light from one slight angle. Then how we examine lens? We need a good pupil dilatation for proper examination of the lens. Most of the time we miss certain diagnosis because we just examine with a normal constricted eye. That too, when you put a bright light, definitely the pet is going to constrict the pupil. So we have to dilate the pupil so that we can examine the full lens, full perimeter of the lens. For that, either we can go for tropicamide eye drops or atropine eye drops. Problem with atropine eye drops is that it will have a prolonged action. So pupil will be dilated for a longer time and that can cause some kind of pain and irritation for the pet. So mostly we use tropicamide eye drops. We can use one drop in 5 minutes interval for 3 or 4 times so that adequate dilatation is achieved. So whenever there is a ophthalmic examination case that also suspected for cataract or something, you can ask the pet parent to sit outside, put the one drop at 5 minutes interval for 3 or 4 times. Then they can come inside into a darker room so that the pupil dilatation will be complete and then we can proceed with the examination. A focal slit beam is helpful in identifying the depth of the opacity. Same this image. So we can see the cornea, anterior cortex, then anterior nucleus, and posterior cortex with a slit beam. So that will be very helpful. And another technique is the Purkinje-Sanson images from the anterior and posterior capsules. This aids in the depth localization. This is nothing. You might have seen this uh, 3, 4 spots will be visible with a focal light on the eye. So in that first one, the P1 is formed by the anterior aspect of the cornea or the corneal epithelium. And the P2 is formed by the corneal endothelium that won't be visible in most of the cases. So P1 you will be able to see. It will be an enlarged image. See, you can see in this image. This is the light source, the smaller flame. But P1, the first one you are seeing, is going to be a bigger image on the corneal surface. It will be a bigger image, that also upright image. Then P2, most of the time you won't be able to see. P3 is formed by here. Sorry, in this it is different. But P3 is formed by the uh, lens anterior capsule, which is again same size upright image. And P4 will be inverted image, which is formed by the posterior capsule. In this, that numbering is different. That's why you can see in this itself. P1 by the anterior capsule, which is upright image and enlarged. P3 by the anterior capsule of the lens, which is also upright image, enlarged. And P4 is formed by the posterior capsule of lens, which is inverted and same size. So this is how we assess the depth of lens lesion. This is a little difficult to see. We can rely on ultrasonography in a better way for assessing that localization of the opacity. That also we'll see in the coming slides. Then disorders of lens can be mainly, we can classify them into embryonic developmental disorders, disorders associated with transparency, and position of the lens. These three are the not the major. These are the three lesions you see in the lens. So disorders associated with embryonic development means aphakia, absence of lens. Phaco or phakia means lens. So aphakia means there won't be a lens congenitally. Then microphakia, lens size will be very small. Coloboma means a localized area of which is not formed properly. So a defect will be there in the lens. Then lenticonus or lentiglobus. Lenti also related to lens, terms associated with lenti. So lenticonus means instead of that curvature, it will have an angulation, or it will be having a what to say, more steeper curvature. That is lenticonus. It can be anterior capsule or posterior capsule. Then lentiglobus means enlarged size of the globe. It will be more globular in shape instead of the discoid shape. Then vascular anomalies. In the last webinar, we discussed some vascular anomalies. To explain that, it's like in the embryonic stage, there will be a connection or a vascular connection from the retina to the posterior aspect of the lens, which supplies nutrients to the lens. Pupillary membrane, we say, hyaloid membrane, we say, or hyaloid vessel. So when the embryo or the fetus develops, that hyaloid vessel will be attenuated into a fibrous tissue, and then it will not be there in the adult or the uh, postnatal stage. Sometimes that vascular supply from the retina to the lens persists, and that can cause opacity and further complications. So that is vascular anomalies. Then congenital luxation. By birth, there will be luxation of the lens, and congenital cataracts. Then transparency, obviously we know about cataract. Then another condition that causes a loss of transparency in lens is nuclear sclerosis. Then regarding position, it can be either anterior or posterior lens luxation. Can be subluxation or complete luxation of the lens, either into the anterior chamber or into the vitreous chamber. So last webinar also, we discussed about the B mode ultrasonography in the diagnosis and study of lens. So just to refresh, or those who haven't been in touch with B mode ultrasonography for eye, this is how we see in a longitude transverse view. So first you will be seeing anterior capsule of lens and anterior epithelium of cornea, posterior endothelium of cornea, then the anterior chamber, anterior capsule of lens, lens material, then posterior capsule of the lens, then the vitreous, and finally the retina. Here the optic disc, optic nerve, and retrobulbar fat on either side of the optic nerve. This is how we see eye under B-mode ultrasonography. And regarding lens, so we can see anterior chamber. This is the lens axial length. The axis. This is the axis of lens, and this is the axial length of lens. And from one side ciliary body to the other side ciliary body is the lens equatorial length. And entire length is the globe axial length, and this is the vitreous chamber from the posterior capsule of lens to the retina. So this is how we measure the size of different structures and chambers of eyeball. So ocular biometry reference values, as I said before, lens axial length can be somewhere around 0.6 to 0.7 centimeters, or 6 to 7 millimeters. And lens equatorial length will be around 1.1 to 1.3 centimeters. This is very important when you go for intraocular lens implantation, because the size of the lens should be matching with this. So yes, this is how we see different conditions under B-mode ultrasonography. This one, obviously, anyone can say the lens is sinking into the posterior capsule or posterior chamber, means posterior lens luxation. So clinically, a posterior lens luxation will look like this. You will be able to see the entire iris and part of the lens which is sinking into the posterior chamber. So what we can appreciate is the aphakic crescent. It's a crescent-shaped part of fundus which is visible without light passing through the lens. That is aphakic. So this is the lens and this is the aphakic crescent, and you will be able to see the full iris. So if you are not able to see part of the iris and you are seeing this aphakic crescent, that could be an anterior lens luxation. So this is a posterior lens luxation ultrasound image. And these are different types of cataract. Here you can see it is in the anterior cortex. Anterior cortical cataract is mostly, posterior cortical cataract it is mature cataract. This is also a full mature cataract. This one can see most of the opacity is in the capsule, anterior capsule and posterior capsule. It's more like a capsular cataract, or it can be a diabetic cataract where the lens is swelled up with water clefts. And one more thing, that integrity of the posterior capsule is damaged at this point. So that means there is a rupture on the posterior capsule. And because of the rupture, there will be a pull for the vitreous and subsequently for the retina also. Retina is also detached in this. Here, here is the detached retina. Here is the loss of integrity of the posterior capsule. Here also, this is more like an anterior capsular cataract. Anterior capsule alone has the opacity. Here it is not having any opacity. Then here it is a mature cataract with the retinal detachment. The typical flying seagull appearance we can see in this. This is another diabetic cataract. So the lens thickness is somewhere around 0.87 centimeter. So in diabetes, that lens swells up. So the lens thickness will be more compared to the normal size. Here, this is the lens thickness. And here, this is also a diabetic cataract with the posterior, this is the lens capsule, posterior capsule that got ruptured, and This is the posterior capsular rupture. In such a case, we cannot go for cataract surgery. It will end up in a disaster because integrity of the posterior capsule only help us maintain the uh, anterior and posterior chamber intact. Okay. This is another posterior lens luxation with the cataractus changes in the lens. Lens is supposed to be here, but it came here. Then nuclear sclerosis. This is the first condition that is causing opacity of the lens. It is very common in aged animals. uh, what happens is that lens cells are continuously produced from the equator or the periphery, and uh, they will newly formed cells will keep pushing the older fibers towards the center or the nucleus. So what happens ultimately, center will get compact with the older cells. So that causes one kind of opacity. Then the second thing is uh, that biochemical property of the protein also changes as they age, and it gets more compact. That also causes loss of elasticity and increase in the light scattering. So it will give an appearance of a lens within the lens. In this picture, you can see that the eye is completely dilated. Iris is completely dilated. Pupil is completely dilated. So we can see the lens fully. And here, center alone, there is a kind of opacity. Still, you can see the reflection from the fundus. Here also you can see the fundic reflection. In case of cataract, you won't be able to see the green or yellow or reddish color of reflection from the fundus. But in nuclear sclerosis, you will be able to see. There is that importance of dilated eye examination, so that you can differentiate between nuclear sclerosis and cataract. Nuclear sclerosis, the opacity will be only in the center because the older cells are getting concentrated in the nucleus. And coming to our major topic, cataract. The word cataract, it's a Latin word, and it means waterfall or a furious rush of water, which causes some kind of opacity. Water, if it is stagnant, it will be transparent. But if you see a furious rush of water, a waterfall, there will be a kind of opacity. That could be the reason why they named it cataract. So, uh, usually, lens protein, as I said, 34 percentage of protein, and that 34 percentage of protein is divided into soluble protein and insoluble protein. Soluble or crystalline protein accounts for 85 percentage, and insoluble albuminoid protein accounts for 15 percentage. So, by any cause, that alteration in the soluble and insoluble protein ratio happens, there will be opacity. Insoluble protein will be more opaque. Then, when there is an increased proteolytic enzyme activity happening within, or any alteration in the lens nutrition or osmotic balance between the fluid, aqueous, and lens, or any changes in the energy metabolism and protein metabolism can cause opacity of lens. When all these alterations happens, or increased proteolytic enzyme activity happens, or change in the soluble insoluble protein ratio happens, there will be rupture and death of lens fibers. And this will cause a loss of transparency of lens or the capsule, and finally end up in cataract. Exact mechanism of cataract development is not yet uh, derived, but these are the multiple causes that result in cataract formation. So, based on the location of that opacity, we can divide cataract into anterior capsular, means on the anterior capsule of the lens. You can see it as a focal opacity. Then it can be cortical on the cortex. There you can see the Y-shaped suture. So from this we can say that it's on the anterior cortex because the Y is upright. If it is posterior cortex or posterior capsular, it will be inverted Y shape like in this one or this one. Then anterior or posterior nuclear cataract in the center only. So here there will be a doubt that it can be either nuclear sclerosis or cataract because it is in the nucleus only. Lens nucleus only opacity has developed. But there is a difference. You can easily say nuclear sclerosis, you can see the fundic reflection. Here, the center part, nucleus part, you won't be able to see the fundic reflection. That means it is a nuclear cataract. Then fetal nucleus means the very center will be very smaller lesion also, and most of the time it will be congenital. Then posterior subcapsular and sutural on the Y-shaped suture, there will be opacity. These are the different types of, or based on anatomic location, different types of cataract. Then comes based on the stage or degree of opacity. First stage is the incipient cataract, means it is the very earliest stage, small opacity. Most of the time, pet will be able to see. Pet owner might not even notice this opacity because the animal is able to navigate, able to see, able to play, fetch, and all. So most of the time they go unnoticed. It will be a mild opacity only. With the dilated eye examination, proper ophthalmic examination, you will be able to see that of the opacity. Then next stage is the immature cataract. So it is easily observed. It will be a diffuse opacity and it won't block the light going to the fundus. Partially light will be entering. So PET will be still visual if the pupil is properly dilated. And this stage also, it's difficult for the pet parents to diagnose if they are not that much observant, but you will be able to easily identify. Then comes the mature cataract. At this stage, light will not go inside. There won't be any tapetal reflection. There will be evident opacity for the pet parent to appreciate it. So that stage, they will diagnose, they will identify that and bring the pet to you. So light can penetrate inside, but there won't be any image formation. That is the problem. So since light enters inside, you will be able to see the uh, PLR, pupillary light response, and dazzle response uh, if the retina is fine. That also I'll discuss further. So in this stage, there won't be vision. Animal will be blind, but PLR and dazzle, pupillary light response, will be there because some amount of light will definitely go inside, but an image will not be formed, so the animal will be blind. Menace response will be negative at this stage. Then comes the intumescent cataract. Intumescent cataract is a characteristic sign of diabetic cataract, means the lens is swelled up due to fluid imbibition. So there you can see some water clefts in the lens. This Y-shaped you can see like a cleft, and water is filled in between. So they are known as fluid cleft or water cleft. You can see that in case of intumescent cataracts. And the lens size also will be bigger. Then comes the hypermature cataract. Hypermature cataract means there will be resorption of water and protein. So you will see loss of that opacity here and there, or mottled appearance you will be seeing. And the lens capsule also will be wrinkled, or shrinkage of lens happens. And some depositions also will be seen on the capsule. Even post-surgery, you will see that depositions, and it's very difficult to remove even with phaco, that capsular depositions. Because if we try too much to remove that, capsule can get ruptured. Then some cholesterol crystals also can get deposited on the membrane. So that is hypermature cataract. Then comes the Morganian cataract, or it is the last stage of liquefaction of the cataract. So, and almost entire cataractous protein has got liquefied. So it might regain vision based on the retinal function and other ocular structures. If other structures are fine, in a Morganian cataract, pet will be able to see. Then comes based on etiology or the causative agent. We can say it can be congenital cataract by birth. It is inherited or due to other in vitro cells, like in the fetal stage, some infection or trauma, something that affected the fetal development and causing congenital cataract. Then another one is acquired inherited cataract. It can be due to genetic defects and it is the most common cause in dogs. Then metabolic due to hyperglycemia, diabetes, hypocalcemia, or nutritional deficiencies. And traumatic cataract due to some injury, trauma can cause cataractogenesis. Then secondary due to inflammation, retinal degeneration, or due to chronic glaucoma also. Nutritional supply to the lens can get affected and can cause secondary glaucoma. So congenital cataract, it is typically, it will be, as I said before, it will be in the center of the lens or on the anterior or posterior capsule. Center of lens, as I said, it represents the embryonal or else the fetal region of the lens. So that area you will see or on the capsules. Congenital capsular cataract develops due to vascular anomalies, persistent pupillary membrane, or as I said, hyaloid membrane. All these vascular anomalies are associated with the capsular opacities because these vascular remnants or pupillary membrane, they get attached to the lens capsule. That attachment, that area of attachment will develop opacity. Then isolated anomalies or else primary congenital cataract. They don't progress further. Most of the time, whatever opacity is there will remain there lifelong. And improvement in vision can be observed when the pet grows further and normal few fibers are formed. And it can be secondary. I mean, with the other ocular anomalies like microphthalmos. Microphthalmos and congenital cataract can come together. In such cases, animal most of the time will be blind only. Then there are some conditions or congenital anomalies like inherited retinal dysplasia, skeletal dysplasia complex in Labrador retrievers. In that case, we can see congenital cataract. Then skeletal dysplasia, retinal detachment in Samoyed breeds. Retinal dysplasia in the English Springer Spaniel. In that, Labradors are very common in our place. So that can be cause for congenital cataract or complete congenital cataract. That is described in case of Persians, but very rare. Dogs, it is common. Then acquired inherited cataract, which is the most common one we see. Even though it is inherited, most of the time they show that or the development will be during the juvenile phase or senile phase, like after 4 or 5 years only. It need not be there since the puppy age. And these are generally progressive and can result in blindness. And many retrievers are very common for cataract development. And German Shepherds, actually, most of the breeds which we get have this condition. Then comes the metabolic cataract. Most common one is diabetic cataract. So usually glucose metabolism end up in lactic acid formation. But when the blood glucose level or aqueous fluid glucose level is too much, that pathway is shifted to sorbitol pathway and sorbitol is produced, which cannot be diffused out of the capsule and resulting in accumulation of sorbitol. So increased sorbitol content inside the lens will absorb more water because of the osmotic gradient and the lens swells up and water cleft and all forms. So this is basically happens when the blood glucose level is high, aqueous humor glucose level increases. So instead of normal routine pathway, sorbitol pathway is initiated and more sorbitol is produced within the lens, and increased sorbitol concentration causes water reabsorption and lens swells up, resulting in cataract. So in younger dogs, aldose reductase activity is high and they are more susceptible for diabetic cataracts. And initially, they will be visible like this. Vacuoles we will be seeing in the periphery, equator region. So Again, this is there is the importance of dilated eye examination. Early stage of diabetic cataract, in the periphery only, you will be able to see vacuoles formation. Then slowly they progress towards the center. So there is one experimental drug, kinostat, um, for the treatment of diabetic cataract. It is under investigation. Then next one is hypocalcemia. In case of parathyroid dysfunction or hypocalcemia or nutritional imbalances can cause alterations in the cell membrane permeability, and that can result in focal anterior and posterior cortical opacities. Here you can see focal opacities, small dots kind of. Here also. On the suture line also, lens fibers you can see. This is hypocalcemia. Then another one is nutritional deficiencies, especially in puppies fed with the milk replacement diets or home formulated diets. They usually show some kind of improvement after weaning when they get proper nutrition. And most of the time it will be in the cortex or the fetal cortex. Then traumatic cataract means when there is a trauma or a blunt or perforating injury that will damage the capsule and causes formation. Usually, this happens in unilateral occurrence because trauma happens. Usually, it won't happen bilaterally. So, unilateral cataract you can suspect for a traumatic cause also. Most of the metabolic and all will be bilateral. And when the lens capsule ruptures, there will be severe intraocular inflammation because of the escaped lens protein out of the capsule. And cataract formation or the opacity formation can happen long after the incidence of trauma. So it will be difficult to correlate with the trauma. But if you ask in detail, they might say a history of trauma long back. And the complication associated with this kind of cataract is glaucoma because of the uveitis, sometimes adhesions happening due to the trauma, anterior or posterior synapse and all. So in this picture, you can see opacity on the lens and a similar opacity on the corneal surface also. It is duplicating. That means an injury happened and it has injured the anterior capsule of the lens that developed the cataract. Here, it is caused by a blunt trauma and cataract is on the anterior suture. So it's an upright Y. Then cataract secondary to ocular diseases like inflammation, as I said before. Uh, most of the time it will be capsular due to pigmentation or fibrin. Like a corneal ulcer, deep penetrating corneal ulcer has happened. There was bleeding inside the anterior chamber, or there was infection inside the anterior chamber that somehow got settled. So the fibrin and all that depositions happens, or the leftover fibrin will get adhesions onto the anterior capsule. That can cause capsular opacity and cataract. Then another reason for inflammation is alteration in the composition of the aqueous and will impair the nutrition to the lens. It is very common in case of cataracts because they are cats, because they are more prone for injuries and fight injury and secondary inflammations. Then retinal degeneration. Progressive retinal atrophy is a very common in German Shepherds, Labradors, and all. In such breeds, this can further develop into cataract. It's very common, but usually late in the progression or the age. It usually happens in aged pets. And reason for that is that the degenerating retina produces a diffusible product that will damage the lens nutrition and metabolism and can cause opacity. Then chronic glaucoma. Aqueous humor will be stagnating and there won't be enough nutritional support for the lens and that can cause cataract. And one more reason is that increased IOP will affect the lens epithelium. It will be compressing the lens epithelial cells and causing opacity. Then coming to the treatment for cataract, there are many trials happening for the medical management of cataract, like antioxidants and reactive oxygen species scavengers, because oxidative changes are happening, like L-cysteine, vitamin E and C, carotenoids. Then all these products protect the lens from reactive oxygen species and peroxides. And how much effective they are, it's still under study. There are many products available in market also, like Glow Eye. It is a bilberry extract. Then high cumin or curcumin product, nano curcumin products. They contain nanoniced curcumin, which is an antioxidant. So they all work under the same principle of reactive oxygen species scavenging. Then aldose reductase inhibitor. Then drugs that dissolve the crystalline aggregates. So as I said, crystalline and albuminoid proteins are there. Crystalline is a soluble protein. So when they aggregate forms, we can dissolve the crystalline aggregates and thereby reduce the opacity. Very common drug, lanosterol. So many studies are happening, and a lot of people are trying with lanosterol. I have also tried lanosterol for few cases of immature cataract, but I'm not sure about the efficacy of lanosterol in case of immature cataracts also, because I didn't see any evident progression of cataract, though there were no positive or resorption of that cataract in such cases also. It is persisting like that itself. Could be because of lanosterol, or just like that it is persisting in that stage. I don't know. So further studies are required for that, and more trials are needed. There are some studies saying that there was reversal of protein aggregation, but not confirmatory. Then surgical management of cataract, which is the, as of now, this is the gold standard for cataract management. There are two techniques, intracapsular cataract extraction and extracapsular cataract extraction. Intracapsular cataract extraction means we remove the cataract within the capsule, with the capsule. And extracapsular means we leave the capsule there and remove only the cataractous protein or the inner content alone. So phacoemulsification is in a way a type of extracapsular cataract extraction only. So we'll see one by one. Before that, how to select a case for surgery. First of all, we have to see the history and other clinical signs of the pet. We have to differentiate whether it is really cataract or it is nuclear sclerosis. Then patient's health profile, general health, whether the pet is diabetic. If he or she is diabetic, first we have to correct that. When the pet is hyperglycemic, it's not advisable to go for a surgery because it can cause further complications. So once the glucose levels get stabilized with insulin therapy and all, we can proceed with surgery. Then based on the stage of cataract, which stage it is, that also matters, because sometimes it can affect the quality of the capsule. So when you proceed with surgery, it can cause complications. So see whether it is in a proper stage of performing a surgery. It is a hypermature cataract and all, capsule will be irregular and all, and capsular opacities will be there. We should be aware of this so that we can inform the pet parent before itself about the possible complications also. And any other ocular abnormalities or diseases. As I showed that ultrasound images, sometimes there can be damage to the posterior capsule of the lens. In such a case, it is not advisable to go for phacoemulsification or some surgeries like that. Or if already there is retinal detachment, there is no point in going for cataract surgery unless it is causing lens-induced uveitis or any other complication. Because even though we go for surgery, chances of the pet to regain vision is less because of the retinal detachment. Then pet parents' cooperation and understanding. Obviously, surgery is 50% only. Post-operative care is another 50%. Proper medication administration of eye drops, then preventing the pet from self-mutilating. All these factors are important. In case of a human being, it is very not that difficult because they wear the black color glasses and ask them to sit inside the house, not to get exposed to dust or high intensity light. They will do that, and the proper administration of eye drops, medication, and all. One more thing is that compared to human eye, immunological reactions are more in case of dogs and cats' eye. So we have to inform the parent about that also. You cannot expect that smooth recovery in animals. You have to give aggressive, intensive, anti-inflammatory and antibiotic therapy so that there won't be any immunologic reactions because we are going to open the capsule and let the lens protein come out. So there will definitely be an immunologic reaction or inflammatory reaction. Should be ready to address that, and the parent should be ready to address that. Sometimes the temperament of the pet will not be good, or they won't cooperate properly for eye drop administration or tablet administration. Very aggressive dogs, it's not that easy to take care of them in the post-operative stage. So the pet parent should be aware of all these things. Then anesthetic risk, obviously, compared to human, we have to give general anesthesia to proceed with any surgical procedures in the eye. So anesthetic risk should be explained properly, and you have to consider that also while doing the preoperative assessment. Then pre and postoperative medication, as I said before. Then visual status, because when a pet parent comes to you for cataract surgery, their expectation is that the pet is going to regain vision postoperative. So we have to see the pre-cataract stage, means whether the pet was able to see properly before the cataract development, or already it was blind and later cataract has developed, and whether there is chance for the pet to regain vision after surgery. 100% nobody can say, but at least whether there is a chance or not, that we should be aware and we should inform the parent. And uh, if there is no chance of uh, regaining vision also, sometimes we have to go for the surgery, like in case of anterior lens luxation. So anterior lens luxation has happened. Pet is not having any chance of regaining vision. Still, we have to go for surgery and we have to educate the pet parent that surgery is necessary. Why? Because anterior lens luxation causes secondary glaucoma. Lens is luxated into the angle between iris and cornea, where the aqueous humor drains. So lens occupies that iridocorneal angle, and it will avoid or prevent the drainage of aqueous and will cause glaucoma. So glaucoma is a painful condition. It will affect the quality of pet's life. So we have to go for surgery, despite the fact that the pet is not going to regain vision. Then need for intraocular lens. So in human, lens accounts for the maximum refractive power of the eye, and without lens, we can't see. But in case of dogs and cats, because of the curvature of cornea, lens accounts only for 30 to 35% of the total refraction of the eye. So even if you remove the lens, pet will be able to see. Only thing is that the proper focus might not be there, but they will be able to see. They'll have a good quality of life even without an intraocular lens. But if they want that fine focusing also to be there, we can use intraocular lens in case of pets. And preoperative assessment, as usual, ophthalmic examination of ophthalmic reflexes, Nana's reflex, pupillary light response, dazzle reflex. All these are important to assess the visual status, whether there is a chance for regaining vision. Then STT, Schirmer-Tear test. It's very important, especially in case of diabetic patients, because diabetic pets tend to develop dry eye. So we have to check tear production. And one more thing, post-surgery also, tear production or the tear is the vehicle for the medicines we apply topically, eye drops. So if there is no proper tear production, medicine will not be absorbed properly and the pharmacokinetics of the medicine also will get affected. So we have to check the STT levels, fluorescein dye test to identify whether there is any other corneal pathologies existing there. Then ultrasonography, as I mentioned before, preoperative CBC and biochemistry as a routine pre-anesthetic checkup. Then electroretinography. Electroretinography is to assess the retinal activity because in a normal dog, we can at least see the retinal vasculature, optic disc, reflectivity and all by using an ophthalmoscope. But when there is a cataract, lens is opaque and we cannot see the fundus. So in that case, we don't know whether the fundus or retina has enough vascularity, whether the optic disc is of normal structure or anatomy. What is the status? We don't know. Maximum possible, we can do ultrasound and see whether there is retinal detachment or not. But electrical activity or the nerve innervation of the retina, we can assess only by electroretinography. I don't have the facility here, so what I depend on is dazzle reflex. Dazzle reflex is a subcortical reflex, means when the optic disc and retinal function are good, there will be a good dazzle reflex. Dazzle reflex is nothing. When you put strong light into the eye should blink. So this is a positive dazzle reflex. She's Arya. She's an 8-year-old golden retriever with nuclear sclerosis, but she has a very good dazzle reflex. So that is dazzle reflex, and whenever there is a healthy retina and optic disc, dazzle reflex will be positive, even with the central lesion. So we can depend on dazzle and pupillary light reflex instead of electroretinography for assessment of visual status and as a prognostic indicator. PLR alone will not be helpful, but this one is a very good prognostic indicator for post-operative visual outcome. Then preoperative requirements. So general ophthalmic set microsurgical instruments. This is an eye speculum. This is a castrovisucorneal scissor. Then this one is a St. Martin forceps to hold the conjunctiva. Then this one is an irrigation cannula, which is blunt and slightly curved. This we use for hydrodissection. I'll discuss this later. This one is also ophthalmic cannula. This will be blunt and little angular at the tip. Then this one is a capsulorhexis forceps for making an opening in the capsule. We use it. It has a sharp edge. Then needle holder, ophthalmic needle holder. Suture tying forceps. This one is a Sinski forceps just to hold that lens. And this one is a wire loop, lens loop. This is to scoop out the lens in case when we do like intracapsular cataract extraction. And this one is a keratome, which is 2.8 millimeter in size. There are different sizes available. For cataract surgery, generally we use this 2.8 mm keratomes. And some other disposables which we use in ophthalmic cataract surgeries are oro blue or trypan blue. Trypan blue is a dye which stains the capsule. So when you inject that and wash off, that capsule alone stains. So we can easily differentiate the capsule from the underlying lens material. Then this one is an ophthalmic cannula, same this one. Then this is a viscoelastic material, which we use to maintain the tectonicity or the globular nature of the eyeball during the surgery. Because once you make an opening, all the aqueous fluid will flow out and the eyeball will collapse. So to visualize properly and to do the surgery or the manipulations inside, we have to inflate the globe. For that, we use this viscoelastic material. And at the end of the surgery, we should remove all the viscoelastic material and then only put the sutures. It should not be retained inside. So intracapsular cataract extraction means we remove lens along with the capsule. So this image, you can see that the lens is occupies the anterior chamber. Up to here, we can see the iris. Here, we cannot see the iris. That means the lens came forward in between the iris and cornea. That is why we are not able to see the iris at that region, this region. So this is anterior lens luxation. So in luxation cases, we have to remove along with the capsule. So surgical procedure is that position the eyeball in the center with the stay sutures. This many stay sutures are not necessary. One or two will be enough. And position the eyeball centrally. Then here we make the incision with the keratome. 2.8 mm I showed before. No? That one we can use. This area is known as the limbus at the margin of cornea and sclera. Make an incision. Make sure that you don't tunnel through the cornea. Sometimes what happens, we keep the keratome parallel to the cornea and it can tunnel through the cornea. So that should be avoided. So what we usually do is initially keep it perpendicular to the cornea. Just partially enter the cornea, then tilt it so that it will go into the anterior chamber. And one more thing, it should not damage the iris also. Once you touch the iris, it will start bleeding from there. That also will be difficult. So when there is iris bleeding, you can use diluted adrenaline solution intraocular so that it will stop the bleeding, or visco material you can inject. That also will stop bleeding. Anyway, so while putting the incision, it should be on the cornea at the limbus and avoid tunneling and avoid touching the iris. Then usually we have to make a dorsal in aspect of the eyeball, 160 to 180 degree incision you have to make. First to make a nick or a keratome incision, then extend it with the corneal scissors like this. So 160 to 180 degree incision we have to make. And after that, you can use any mydriatic like adrenaline or tropicamide to dilate the eye. Then slowly scoop out the lens, and while doing with the lens loop, and while doing that, cut the attachments of the vitreous onto the lens capsule. Slowly we can scoop it out. And sometimes little part of this vitreous will come attached to the lens. Instead of pulling that, we can slowly cut them off so that it will not give a traction to the retina. Because here you're pulling the lens, vitreous is pulled, vitreous is attached to the retina, retina also will be pulled. So instead of giving that pull, we can cut it here. So vitrectomy it is. Then again after that, reflate it and start suturing like this. And by the end of or halfway sutured, remove all the viscous, irrigate nicely with the balanced salt solution, then complete the suturing. Interrupted sutures with the 80 sutures we can use, Vicryl 80 or silk we can use for corneal suturing. So this is intracapsular cataract extraction. Postoperatively, there are chances for intraocular inflammation and infection. So to avoid these two, aggressive antibiotic and anti-inflammatory therapy is required. Eye drops should be applied every 2 hours minimum. And orally also anti-inflammatory medications. Carprofen is a very good anti-inflammatory medication for eye that we can use. Then adhesions can happen. Iris can get adhered to the vitreous. To avoid that, we can keep the pupil completely dilated with the atropine eye drops. Complications, inflammation, ciliary body hemorrhage from excessive tension on zonal artery. So we are removing the lens as such. So ciliary body is, means that zonules are attached. So ciliary body hemorrhage can happen because of the traction. So in such a case, when there is hemorrhage during the surgery, as I said before, we can use diluted adrenaline injection into the, not injection, instillation into the eyeball. Then loss of vitreal barrier. Vitreal barrier is nothing but it is attached to the posterior capsule of the lens. When you pull the posterior capsule, as I said, vitreous also will be pulled and vitreal prolapse can happen. Subsequently, retinal detachment also can happen. So that is one possibility. Then increase the chance of glaucoma because of all these lesion conditions. And long-term complications, elevated IOP, I mean glaucoma, and prolonged inflammation, retinal detachment, persistent corneal edema. Because of all this happening, edema can develop. Then comes the second procedure, extracapsular cataract extraction. So there we remove only the lens cortex and nucleus, and the capsule will remain there. So the vitreous barrier is maintained. The capsule, since the capsule is there between aqueous and vitreous, so that will act as a barrier. Capsule will act as a barrier, and it will prevent the vitreous from prolapse and retinal detachment. So if you do it properly, it is a very successful technique. So phaco emulsification is a type of ECCE only. So what we do is same like ICCE, we position the eyeball centrally, dilate, put the incision in the limbus. Then next stage is that we make same 160-degree dorsal limbal incision. Then we do a capsulotomy. We make a small tear on the anterior capsule of the lens with a needle. Normal or injection hypodermic needle only. We make a small bend with an artery forceps at the tip, and we can use it to make a tear on the capsule. Then holding on the tear with the capsulotomy forceps, we have to make a continuous curvilinear capsulorhexis. I'll show in the next one. So this is how it is. First, we make a small tear, hold on the tear, and rotate the capsulotomy forceps so that you make a continuous curvilinear capsulorhexis. So finally, it will be like this, and you can take out this capsule, this part of capsule. So we made an opening in the lens. This is how it will be. This is the removed part of capsule, and there will be a round visible. In the next slide, I can show you. This is how we do it. We made an opening on the capsule like this. Here we opened it. Then we insert a needle into the lens or between the capsule and the cortex and do a hydrodissection or inject balanced salt solution into that space. So what happens? Sorry. This is the capsule. This is the lens cortex. You're putting a needle in between that space and injecting fluid. So that fluid will come and occupy the space in between. So that will separate the lens cortex from the capsule. A simple example I can say, from the idli batter we will put into the tray, no? How we remove it? We put the spoon between the idli and the plate and scoop it out. Same thing happens. We inject the water in between and that idli or the lens cortex will get separated from the capsule. Then we can easily take it out. Same thing happens. That is known as hydrodissection. Separate that what is okay. So hydrodissection, I think it is clear. We put the needle in between the capsule and the cortex of the lens, push the balanced salt solution so that lens material will get separated from the capsule. Then we can remove it as such. This is how we remove it with the lens loop. So here you can see that the lens capsule is remaining. This is the anterior capsule where we made an opening. This is the posterior capsule which is intact. And the lens material as such we are removing. And after that, sometimes some particles will retain within the capsule. To remove that, we can use this irrigation aspiration cannula. This is a Simoki cannula where you can simultaneously irrigate from this side and aspirate from the other side. So with that, we can remove all the small particles remaining within the capsule. And after that, reflate the eye and close the corneal incision with the interrupted sutures. Same 8-0 or 10-0 we can use. So this is ECCE. Post-operative complications, inflammation, fibrin formation, ciliary body hemorrhage can happen. In case if posterior capsule is damaged, then vitreal prolapse also happens. Then comes the phacoemulsification. It is an advanced form of extracapsular cataract extraction only, where in ECC, what we said, we remove the lens material from the capsule as such. But in this one, we fragment the lens material, emulsify it, and then aspirate it. So we don't need a bigger incision. Through a smaller incision, we put a probe, emulsify the lens material, and remove it. So up to capsulotomy and capsulorhexis, it is same procedure. Position the eyeball centrally. Here you can see I have used only one stay suture and an eye speculum to position the eyeball centrally. Then one limbal incision we make. And through the limbal incision, these two are different eyes. That's why the positioning is different. But through the limbal incision, we put a small bent needle, and with the needle tip, we make a capsular rupture. And holding that ruptured end, we make a circular capsulotomy. So in this video, here you can see that capsule of the lens, eyeball is completely dilated. Iris is somewhere here. This is fully lens, and the anterior capsule of the lens is stained blue with the trypan blue stain, and I made the capsulorhexis. So a circular part is white because I removed that part of capsule. And in between this capsule and the lens material, we put the phaco probe and break the lens into multiple fragments, emulsify it and aspirate it. So what happens in phacoemulsification is irrigation, continuous irrigation of balanced salt solution, then emulsification, fragmentation and emulsification of the lens material, and aspiration of that emulsified content happens. This is how it works. So in this video, you can see clearly what happens during phacoemulsification. The bigger fragments of lens will be broken down into smaller ones, and slowly they get dissolved and gets aspirated. You can see that only one small incision is made, and everything is happening through that only. So the trauma caused is less. And once the lens material is removed, we can see the fundic reflection more clearly. And throughout the procedure, cornea should be kept hydrated with the distilled water so that it will not go to dryness. And this is how we look after the complete removal of cataract. So you can see that capsulorhexis, anterior capsule, the tear we made circular one, and little blue discoloration of the anterior capsule because of that trypan blue, and a fundic reflection, green color reflection also we can see. And here is the incision. We are closing it with the 8-0 vicryl suture. Single suture is enough. Sometimes without suture also it won't leak because most of the time we put the incision on the dorsal aspect. So it will not leak, but for the safety we can put one suture maximum. So for prognosis, post-operative normal vision can be achieved by implantation of artificial intraocular lens. And in dogs, preferred one is 41 diopter because we cannot exactly assess the power required. So universally we use 41 diopter. Then aphakic dogs or without lens, just remove the cataract and retain the capsule alone. Still can see because lens contributes only 30%, 30 to 35% of refraction in case of dogs. And more than 95% of patients regain useful vision post-phacoemulsification. So this is the intraocular lens we use in pets. This is the optic and this is the haptic. So it can be folded. Here it is folded and an applicator will be there which can be injected. So this part goes inside. When we inject, that folded lens will go inside and inside the capsule and it will get spread. This haptics will be what to say engaged and it will hold the lens in position. When you go for intraocular lens placement, one thing, the posterior capsule should be strong enough. There should not be any tear or damage to the posterior capsule. Because if the posterior capsule is damaged and you are putting an intraocular lens, it can get displaced into the posterior chamber. So the capsule should be uh, proper enough. And the anterior capsule or excess you made, that opening you made, this opening should be of the proper size. If it is too big, that also won't retain the IOL inside. It can come out. Then it will be difficult because while engaging that in IOL, it is folded and once it goes inside, it spreads. To take it out, we have to make a bigger incision only. It won't come through the 2.8 mm incision. So that should be considered before putting IOL. So same surgery. This is preoperative. This is Joe. He is a 6-year-old Labrador. He had a genetic inherited cataract. So he had a negative Manas response, positive strong, PLR, and strong basal reflex. So before surgery, visual obstacle course test. It's not obstacle course test, just walking itself, he was hitting everywhere. He's hitting there. And the feeling gait, they will, blind dog will keep the legs, like they keep very cautiously, feeling gait, we say. And the head will be kept down and they sniff and walk. So this was the preoperative. And post-operatively, this is Joe. You can see the fundic reflection. This is immediately after the surgery. That's why that little pain and inflammation will be there. That's why he's showing some photophobia, blepharospasms. You can see the fundic reflection. This is messy post-operative, immediately post-operative. So complications which we can expect and post-operative care, intraoperatively damage to the corneal endothelium because corneal endothelium is a structure which is not regenerative. Once damage happens, it is permanent. So if any of your instruments are damaging the corneal endothelium or the lens particles constantly irritate the corneal endothelium, that can cause permanent corneal opacity or cloudiness of the cornea that we cannot do anything. Sometimes even without damaging anything or happening, that lens met protein, anyway, it is coming into the anterior chamber, no? So that can damage the endothelium and cause endothelial dystrophy and corneal opacity throughout the life. Still, the pet will be able to see, little bit of haziness will be there. Then rupture of posterior lens capsule. During that phacoemulsification, if the vacuum or the phaco power is too high, or if we use it little carelessly, it can damage the posterior capsule. As I said before, anterior capsule is 40 micrometer thick and posterior capsule is 4 micrometer thick. So it can easily get damaged and can cause too much of complications. Then during the post-operative period, lens-induced uveitis, we are making an opening on the capsule and exposing the lens protein to the immune system of our eye. So it can cause uveitis and can lead to secondary glaucoma, posterior synechiae, post-operative opacifications, retinal detachments, infections, suture failure, or intraocular hemorrhages. Then post-operative monitoring. Usually, we suggest aggressive antibiotic and anti-inflammatory therapy during the first 48 hours of cataract surgery. Eye drops, antibiotic eye drops should be put every 2 hours, and anti-inflammatory, either you can go for steroids or NSAIDs. Especially in diabetic patients, we cannot go for steroids, so we go for NSAIDs, carprofen. Tramadol is a good pain medication, but carprofen will take care of pain and inflammation. So I prefer carprofen. And then antibiotic, obviously, we can go for cephalosporins or penicillins along with the doxycycline. Doxycycline, not just an antibiotic, it has an matrix metalloproteinase inhibitor activity in eye that will reduce inflammation also in eye. So we can combine doxy with any other antibiotic. And one more thing, doxycycline excretes through the secretions. So through tear also doxycycline excretes. So that in that way also doxy is good for eye. Then we can use antioxidants in the postoperative period like vitamin C, then teretiopeptidase, then nanocurcumin tablets you can give. Then other than that, eye drops, hydration of the eye, prevent from dust or intense light, and definitely Elizabethan collar throughout the postoperative period. At least for 10 days, we have to put that. Then routine checkup once in 6 months or once in a year post surgery, because we have to assess. Most of the time, pet parents will realize the problem very late in the process. So we will be able to diagnose it early and intervene with it earlier. So ask them for follow-ups very frequently. And lens-induced uveitis, we discussed preoperatively, it can happen postoperatively also. Phacoclastic uveitis means a traumatic rupture of the lens happens, and lens proteins get escaping into the aqueous humor. It can cause severe pain and inflammatory reaction. And usually hypermature cataracts can cause severe lens-induced uveitis. That's why staging of the cataract is very important before the surgery. There will be severe pain and resultant photophobia and blepharospasms, corneal edema due to the endothelial damage. Ciliary injection means the margins will have a vascularization on the cornea. Meiosis, pupil will be too much constricted. Iris will be darker, or blood vessels will be visible on the iris, or red rubeosis iridis, we say, means reddening of the iris. Then this keratotic precipitates, these pigmentations on the cornea, dot kind of pigmentations on the cornea. And this one is like tenting of the pupil margins. This also you see in case of uveitis. But more than that, evident ones are blepharospasms, meiosis or constricted pupil, and photophobia, corneal edema, ciliary injection. So this is about cataract. Some points might be missing. I tried to cover whatever practically important when we diagnose and go for a surgery for cataract, or when you refer someone for a cataract surgery, or if you are going for a surgery, what all things we have to keep in mind. Anything else to be clarified, or anything to discuss, or any new information that anyone can share, please welcome.
Thank you, Ms. Sindhu. Now the session is open for discussion or Q&A session. So participants can ask their question directly by getting unmuted themselves, or you can post your questions in the query, the discussion page. Okay. I think I have not seen any questions, Sindhu. So
Okay.
I just have two questions. So
Okay.
what are the what the technique you'll be using for differentiating cataract from nuclear sclerosis?
Yes, sir. For differentiating cataract, one first thing is that nuclear sclerosis is the aging process of the lens. So usually you will see that in the senior patients or after 7 years or 7 or 8 years. That is one thing. Then you have to dilate the eye and examine, sir. Nuclear sclerosis will be restrained only into the nucleus of the lens or the center of the lens. Periphery will be clear and you will feel like a lens within the lens kind of appearance. And when you dilate the eye, periphery, there will be clear fundus reflection. Center, still there will be fundus reflection, but little bit of opacity. Usually, I explain to the pet parents with the small example. I don't know how much effective it is, but I used to explain with this. When we keep one sheet of transparent paper or plastic sheet or transparent glass, it will be through and through visible. There won't be any loss of transparency. But if you keep 100 sheets of the same transparent glass or plastic sheet, there will be little cloudiness. No, same like that only nuclear sclerosis will be because it is compactly packed in the center. Cells are compact
Center.
inside
Okay.
in the center. So it will look little thicker and the clarity will be slightly affected, but still you will be able to see the fundic reflection. But cataract, you
Yeah.
won't be
Okay.
able to see the fundic reflection. Immature cataract, you will
Oh,
be able to see, but maybe after seeing 2, 3 cases, you will be definitely able to see which is nuclear sclerosis and which is cataract.
okay. So second
Dilated
thing
eye
is in
examination is important, sir.
yeah, you'll be using just a tropicamide or anything else?
Tropicamide only, sir. Tropicamide only because that will
Plain
have
plain
less
tropicamide.
plain tropicamide eye drops, sir.
Okay. So second thing is so in some cases we'll be having uveitis along with the cataract. So
Yes, sir.
will you proceed for surgery and you'll remove the etiological agent like here is this cataract. So you have said something about cataract induced uveitis.
Yes,
In
sir.
such cases, will you wait for resolution of uveitis or proceed with cataract and then check for uveitis resolution?
Uh, uveitis as such will be very painful condition, sir. So
Okay.
I don't suggest to go for surgery along with that. So that existing inflammation, we have to reduce with the medications and then proceed with surgery will be a better option.
Okay. So any more questions from the participants? So I haven't seen any questions in the chat. Uh, so thank you very much, Sindhu. Okay. On behalf of APA, we extend our heartfelt thanks to you for your insightful webinar today. So normally, we know very well, learning from any expert always brings two things. One is clarity and is the depth of the subject. And today your session actually gave us a very good, excellent understanding of cataracts, Sindhu. And I think our people will keep on learning more things from ophthalmology because ophthalmology is a very unexplored area. So cataract itself is not a very common thing which we operate in a regular clinics like other surgeries. So I think we need some more hands-on on these things for our people to get more acquainted with this subject. Thank you very much, Sindhu, for your time and efforts.
Thank you so much, sir, for giving
Thank
me
you.
this platform. And one more thing,
Yeah,
keep examining the eyes because I'm also learning now only. And keep on examining normal eyes. We will be able to differentiate normal from abnormal. So every case,
yeah, definitely.
let it be vaccination, let it be simple deworming, but just examine the eye. I think that will give a lot of like our
Yeah, exposure and experience, both
perspective
things.
also will change based on that.
Yes, you're correct.
Yes.
So actually, we have some new participants today rather than our regular life members. So our
Yes, sir.
previous webinars on ophthalmology was there in our YouTube channel because we are going as a series. We started from the basic examination and then we're going one after the other. We have completed ophthalmic examination. We have completed ulcerations. We have completed ocular ultrasonography, and today we have completed cataract examination and treatment options. So those who wants to learn these things, all the past videos are available in our YouTube channel. You can please go through. Channel name is Andhra Pradesh Pet Practitioners Association. So we'll have a continuation of the subject. That is the idea. Okay. Thank you very much, Sindhu. Thank you, participants, for your today's participation. Thank you, one
Thank
and
you.
all. With
Thank
this, we
you.
are ending the session. Thank you.